So guys, thank you for joining us tonight. It's my pleasure to introduce Dr. Jodie Semmler. She's a fertility specialist with Fertility SA and Genea Fertility SA. She's here tonight to talk about subfertility and causes and primary investigations. She's been in fertility for over 20 years and also does quite advanced laparoscopic surgery. So Jodie, I'll pass it over to you. Guys, if you have any questions for Jodie along the way, just chuck them in the chat. And we'll interrupt Jodie along the way and just answer the questions that way. Okay, Jodie, I'll pass it over to you.
Okay, thank you. Can everybody hear me, hopefully? So I'm going to talk on subfertility, the causes, primary investigations and treatment options. You'll have to forgive me, but I'm finding this a little bit unusual to be speaking on a webinar. I'm used to doing face-to-face talk, so I'm not used to just staring at a computer screen. So that's me there, and I'm actually wearing the same dress, so you'd recognise me. So causes of difficulty conceiving or subfertility, I like to divide it into eggs and sperm they need to meet. So there can be egg factor, sperm factor, and then there can be something stopping the eggs and sperm from meeting. So that's the way I'm going to go through with my talk in that way. So we're going to talk about eggs first of all. Well, causes of subfertility, this is different depending on which demographic you're working with. But if we're seeing a couple for the first time and working them up for their subfertility, I think there's an estimate of about 30% will have a male factor, so a problem with the semen and the semen analysis. About 30% will have a female factor. About 20% will have a combination of male and female factor. And that's often sort of like you might have a slightly low sperm count and the female may not be ovulating. There's also 20% which are classified as unexplained. And the reason I've got that in next to in quotation marks is because there may be lifestyle and age contributing. So if you've got a couple where the female is 40, 41 and the male's a similar age, and all their tests have been normal, they fall into the unexplained category, but really it's probably age related, with the female being 40. So the unexplained category is always a bit of a mixture, really. So basically, before going on to talk about eggs and sperm, I was going to talk about pre-pregnancy advice, because if couples are going to embark upon getting a pregnancy, I would imagine that hopefully, other than going to Google, which they do, of course, as you all know, hopefully they actually, if they're going to see someone for pre-pregnancy advice, they come and see one of you guys. And basically, they may need a bit of counselling regarding lifestyle issues. So now the accepted level for alcohol is no alcohol at all for women who are trying to conceive. Obviously, stop smoking and no recreational drugs. The other thing that we really struggle with, and I know you guys are seeing it in increased numbers in your general practices, is overweight, people who are overweight and obese. And so that really has a huge effect on fertility. If a female has a body mass index of over 35, she basically halves her chance of getting pregnant, either with natural conception or with IVF as well. And if both the male and the female are overweight, they would, or obese rather, they reduce their chance of conceiving by about 75% with or without IVF. So one thing that you guys can do is at least sort of start talking to the patients about improving their lifestyle factors. Healthy diet, fresh fruit and green vegetables. For women, they need folic acid and some iodine and vitamin D. And most of the pre-pregnancy vitamins will cover this. Possibly for men, they could, some of them like to start on Menavit and things like that, which are antioxidants. There's no real need for first time when they're first trying to actually be on something, but some of them like to, because I've heard all about oxidation damage to sperm and antioxidants. They may need a little bit of advice about fertile times of the cycle. So basically the most fertile time for a couple is 2 days before ovulation and the day of ovulation. So the window is actually quite small. It's quite narrow. It's really only a couple of days a month. So we advise intercourse every 2 days over the fertile time. So basically a woman can, there's all sorts of apps they've got nowadays that they can use as well to help them optimise intercourse at the fertile time. And there's also ovulation test kits as well. The other thing I was going to bring up, which is becoming an area that we're needing to encourage or talk to our patients about, and that's reproductive expanded carrier screening. So basically, reproductive expanded carrier screening, the RANZCOG guidelines are now that all couples who are planning pregnancy should be offered this. It involves screening the female and the male partner for recessive gene mutations and X-linked dominant mutations. Most providers of the test test for greater than 300 genetic mutations. There's two main providers in SA. There's Eugene and there's Sonic Genetics. Eugene is easier to use for clinicians because you can just direct the patient to the website, which has all the information on it. They send out the pack for the patients to do. The test is performed on saliva. And a genetic counsellor is included in the cost. So basically Eugene take care of all of it for you, and they also counsel the patients on the genetic results. So that's sort of quite a hands-off way of doing it. And the other group is Sonic Genetics, where a blood test is required and it requires a request form. Genetic counsellors are available, but the results come through to the doctor requesting the test. The cost is approximately $500 to $800 depending on the lab used, the number of genes tested and whether both partners are tested. So that's actually quite a difficult thing to cover in a consultation, not just for you guys, but for us as well. So I keep the pamphlets in my little box of the Eugene and Sonic Genetics pamphlets, so I can briefly explain to patients and hand them the information to look at, and then we can talk further about it next time, or some of them are actually happy just to go ahead with that. The reason for doing it is, of course, that if both male and female partner are found to be carriers for the same recessive gene mutation, then we've got the ability to offer pre-genetic testing with IVF. So on to eggs. So basically this shows eggs in many of the different forms. The primordial follicles are tiny. They're basically microscopic. And then as an egg grows up, becomes a primary follicle, a secondary follicle. This is an antral follicle, which is going to ovulate soon. And you get ovulation. And then the corpus luteum is developing where ovulation has occurred. And that shows a corpus luteum which produces progesterone as well as estrogen, all in order to get the lining of the uterus ready for a pregnancy. So another thing that we like to actually push the point of is the age factor, because age is the single biggest difference with eggs. Basically, a woman becomes unable to conceive with her own eggs at an average age of 41. So basically, women over 41, it is very difficult for them to get pregnant either on their own or with IVF. And that comes to a shock to a lot of women who think that they can leave getting pregnant until late 30s or 40. This graph shows the fecundity rate, which is the chance of conception per month. And basically, as you can see here, through the mid-20s to early 30s, it's still a reasonable sort of 20 to 25% per month. but then it starts going down quite steeply after age 38. And once a woman is about 45 or 46, the chance of conceiving per month is down to 1%. And after that, there'll actually be a lot of miscarriages as well, like about 70 to 80% chance of miscarrying if you're lucky enough to conceive at age 45. So it's a huge thing that we all need to be aware of in counselling our patients. And I personally think it should be taught in high school, because everything that's taught is all about contraception. But I do not think women and men realise how critical a woman's age is to their chance of conceiving. Basically, oocyte numbers drop off dramatically as a woman ages. Basically, we're born with a million eggs. By the time we reach puberty, which is about here, there's only 300,000 eggs left, and the egg number continues to drop off until basically you go through menopause and there's 0 eggs by the time you hit menopause. Essentially, a woman becomes unable to conceive 10 years before her miscarriage. So it's 10 years before her menopausal age. So that's where the average age of menopause is 51. So the average age of no longer being able to conceive is 41. So, you know, some women are going to go through menopause at age 46. It's not uncommon, which means they're not going to be able to get conceived much past the age of 36. So some of these graphs can be useful when we're counselling women about why it gets more difficult to get pregnant. So anti-Müllerian hormone level. AMH is produced by the developing ovarian follicles, the smaller ones that haven't grown up yet into dominant follicles. And anti-Müllerian hormone represents the number of eggs remaining in a woman's ovaries. It doesn't give an actual number of oocytes, but we can plot it on a graph and show a patient where they are in relation to normal or average for their age. It can be measured at any time of the cycle. It doesn't matter if they're ovulating or not, and it can be measured on the pill even. It might be slightly suppressed on the pill, but only slightly. So at least if women are wanting to get an AMH test done and they're on the pill, you don't actually have to stop the pill. It also doesn't predict the chance of natural conception. A woman with a low AMH, if she has not yet embarked upon trying to conceive, her chance of conceiving naturally is not predicted by her anti-Müllerian hormone level. It basically should be assessed in conjunction with, so AFC is antral follicle count and follicle stimulating hormone. So basically our ovarian reserve testing includes an antral follicle count, which is basically an ultrasound to look at the number of small follicles. So when we have a scan of a woman's ovaries, they can see the little follicles that are about 2 to 9 millimeters. So they're not doing anything. They're the ones that are going to grow up in the next few cycles and try and become the dominant follicle. But the ultrasonographer can come up with an antral follicle count. That is representative. It's like the tip of the iceberg. So that represents their ovarian egg supply as well. And follicle stimulating hormone, that actually goes up as a woman's running out of eggs. So we put all 3 of those together when we're looking at egg supply. But anti-Müllerian hormone level is the one that patients will often come in and ask to have done if they're wondering what their fertility is like.
Jodie, we have a number of patients with a Mirena or Implanon or other things other than the oral contraceptive. Do they have to have those removed if we're going to redo an AMH level? Or
the Mirena, definitely not. The Implanon is probably similar to the pill, that it can be taken. It might be slightly suppressed, but generally the result will be fairly accurate.
Okay.
Yeah. They used to think that it suppressed it a lot, but the studies have now shown that it actually doesn't suppress it by much at all.
Excellent.
So basically, we're able to show plot the woman's AMH on a graph and show her whether she's got normal ovarian reserve, low ovarian reserve, or high ovarian reserve. So that's often the easiest way to explain it, because it can be tricky to explain to patients. So when we're looking, when we're talking about egg quality.
Sorry, Jodie, there's just a question in the chat about the AMH testing. Do you think that's something for GPs to be doing, or do you think that needs to be interpreted with the AFC and the FSH? Is it more, I guess, more appropriate to refer to you guys to have that done, or?
I think it is actually perfectly reasonable for a GP to organise an AMH. The trouble is, it does come when you're organising an AMH, I think you're probably hoping that it comes back normal and you can just reassure the patient. The difficulty is when it comes back low, and it's then hard to counsel the patient on what that means. But I think it's perfectly reasonable for GPs to order an AMH, and then if the AMH is low, send them to one of us to discuss it.
Okay, excellent.
That's
Thanks.
probably. So oocyte quality, so there's no way to directly measure egg quality. The single biggest negative effect on oocyte quality, once again, is age. So I'm going to harp on a little bit about age, but I think age-related infertility is such a huge issue for us at the moment, as couples are delaying childbearing for various reasons. So the most common negative effect on oocyte quality is age, and that is mainly due to chromosome abnormalities, where most of the eggs have an abnormal number of chromosomes. There's also something called oocyte competence, which has got to do with the mitochondria and the energy production systems of the egg. And as a woman gets older, her mitochondria drop off in number as well. Other things that have an effect on egg quality are an increased body mass index, endometriosis, cigarettes, of course. There may be other environmental toxins, which is opening a Pandora's box, but things like the bisphenol A, BPA, certain pesticides and herbicides, and even air pollution may be playing a part in reduced egg quality. We can actually see it when we do an actual IVF cycle. We can actually get an idea of egg quality from the scientists looking at the eggs. They can see if they look a bit granular, or if the zona pellucida, which is like the eggshell, if they can see whether that is abnormal shaped and things like that. So there are sometimes some things we pick up on an IVF cycle which can show what egg quality is like.
Jodie, you might get to it a bit later on, but is there a perfect time to harvest eggs in terms of the patient's age?
That's a good question. Talking about harvesting and freezing eggs.
Yeah.
So basically, it's the sooner the better, but you don't want to be freezing in a person's 20s just because they haven't yet found a partner. So I would probably say early 30s, as a woman might be already beginning. And the other thing is that if a woman is considering egg freezing, that's when an anti-Müllerian hormone level being done can assist a little bit. Yeah. But I would say most of the egg freezing we do here is women in their early 30s, because they still haven't met somebody or they're not in a committed relationship and they're beginning to think about their fertility. And freezing eggs in early 30s, they're still reasonable quality and they survive the freezing and the thawing reasonably well. Over the age of 38 is probably missing the boat a bit with freezing eggs.
Perfect, thanks.
So assessing ovulation. So obviously we ask the patient about their periods and whether their periods are regular. In order to assess ovulation, it's quite tricky because if a woman's got a strictly 28-day cycle, then it's easy. It's the classic day 21 progesterone. But if she has a 35-day cycle, then it would need to be day 28. Because what we're looking for here on this chart is a mid-luteal progesterone. And that mid-luteal basically is halfway between ovulation and the next period. So this is when we need to get the progesterone checked. So if a woman has slightly irregular cycles, it can be difficult to time. But if they've got regular cycles, it's a lot easier. If a woman has got completely very irregular cycles, like spread apart or close together or all over the place, then she's got something going on with her ovulation, and it's not so critical to try and guess the mid-luteal progesterone. Is not going to be possible. Some patients do basal body temperature charts. That basically shows ovulation after the fact. But it can be useful for a patient to then, if their cycles are regular, that can then help tell them when they'll be ovulating next time. Ovulation test kits, as in LH kits, they are actually quite accurate, and so a lot of women will be already using those by the time they come to us to predict ovulation. In women that are still having trouble predicting ovulation, we can do full cycle tracking for them at Fertility SA, where we actually do blood tests and an ultrasound, and we can help detect the LH peak and tell them that they're about to ovulate. So basically testing for ovarian reserve. Just not sure if you're receiving, or are you receiving my headings of my talk properly, or?
Yeah, the top of the title's there. Yeah.
Okay, so good. It's just not on my screen.
Okay.
So ovarian reserve may be reduced even if a woman is ovulating and having a regular cycle. So as mentioned, it's assessed with bloods in a scan done in what we call baseline, which is day 3, 4, or 5 of a period. So the bloods need to be done then, because that's when they should all be low, apart from the AMH. But at the beginning of the period, so day 3, 4, or 5 of a period, FSH and estrogen should both be low. Anti-Müllerian hormone, well, hopefully that'll be high. We also look at ovarian volume and antral follicle count on a transvaginal ultrasound scan. And the antral follicle count is part of what we use to predict a woman's ovarian reserve. If it comes back as low ovarian reserve, then that's a signal for prompt referral for fertility advice. Low ovarian reserve is associated with poor response to stimulation on an IVF cycle, and if the ovarian reserve is markedly reduced, it is associated with poor egg and embryo quality as well. The trick with the ultrasound is that it needs to be done somewhere that is used to doing ovarian volumes and counting the antral follicles, and not every ultrasound provider can do that for us. We use a handful of providers who can do that for us. I'm not sure whether it's kosher for me to advertise those groups or not.
That's fine, Jodie. You can tell us who you refer to. That's fine.
Okay. So basically, it's groups like Specialist Imaging Partners in North Adelaide, or Adelaide Women's Imaging, the ONG group at Calvary, North Adelaide, and Ashford Benson's. They're sort of 4 of the ones that I use, because it is quite a specialised thing to do, to count the number of follicles on the ovaries and give us ovarian volumes. So anovulation, there's lots of reasons for it. Basically, when we look at what the bloods are showing us, this is hypogonadotrophic hypogonadism. So what that means is the pituitary gland is not working, so to put out FSH and LH, and so in turn the ovaries are not working. So that's hypogonadotrophic hypogonadism, and what you see with that is a low FSH, a low LH, and a low estrogen. If it's a premature menopause, you'll see a high FSH and LH and a low estrogen. Hyperprolactinemia is another cause of anovulation. I'll go through this in a little bit more detail on my next slides, as well as abnormal thyroid function. Either hypothyroidism or hyperthyroidism can interfere with ovulation. Polycystic ovarian syndrome is obviously one of the more common reasons for not ovulating, and I'm going to go through these things in a bit more detail in the coming slides. Obesity on its own without polycystic ovary syndrome can prevent ovulation. That's because the raised insulin, so the raised estrogen level, can feed back to the pituitary gland and act as a negative feedback so that we don't get the FSH and LH that we need to promote ovulation. And high insulin levels can actually act directly on the ovary because there are insulin-like receptors on the actual ovary and the oocytes themselves. So if a woman's not ovulating, what tests do we do? So just to get myself a bit more comfortable, we do the day 3, 4, or 5 blood tests. We do a follicle stimulating hormone, a luteinizing hormone, an estradiol level, prolactin, thyroid stimulating hormone, and we can also order androgens if clinically indicated. So if we suspect polycystic ovary syndrome, or if the woman is complaining of things such as hirsutism, which may be signs of high androgen levels, then we would add androgens to our blood tests as well. And then, as mentioned before, there's the ultrasound of the pelvis for ovarian volumes, antral follicle count, and to see whether they're polycystic ovaries on scan.
So, Jodie, with that ultrasound referral, you specifically ask for those things?
Basically, yes, if I'm sending someone off for an ultrasound, I'll be asking for a baseline pelvic ultrasound. A couple of the places that I send people to will automatically be doing antral follicle count and ovarian volumes and endometriosis scan, but I often will write it on there to make sure. So I write for antral follicle count, ovarian volumes, and endometriosis on the actual form. But most of them, they do that routinely, but I probably mostly do write it on there just to make sure. So, hypothalamic dysfunction. Basically, it's a very, it's a very particular, so we're talking about the hypothalamic pituitary ovarian axis. So that's the hormones that come from the hypothalamus that stimulate the pituitary gland to put out follicle hormone and luteinizing hormone, which in turn stimulate the ovary to produce ovulation. So there's a lot of things that can actually cause the hypothalamus itself to not be working properly. That can be significant life stresses, weight-related causes such as anorexia or malnutrition, and exercise-induced amenorrhea, where a woman might be in the normal body mass index but is basically running marathons and things like that. So that can affect the hypothalamus. If the hypothalamus doesn't work, then the pituitary gland doesn't work. There's also other endocrine disorders such as thyroid function, Cushing's disease, and the raised prolactin, which interfere with the function of the hypothalamus. So this is about premature ovarian failure. So basically, if we have a high FSH and LH and a low estrogen, then that is reflective of menopause. It's called premature menopause if it's less than 40 years of age. Between 40 and 46, it's just called early menopause. So this is actually what's quite scary when we're thinking about the ages at which women are trying to conceive these days. Basically, more than 10% of women will go through the menopause before age 46, which means those women will have trouble conceiving before age 36. So if premature menopause is diagnosed, then we do further investigations such as chromosomes, Fragile X, and bone mineral density. Obviously, treatment options with someone who's gone through menopause early are very limited. If they're wanting to be pregnant themselves, they really have to look at the donor oocyte program. But meanwhile, we can't forget that they need estrogen replacement therapy whilst going through this. So raised prolactin or prolactinoma, basically in order to diagnose a woman as having raised prolactin, we need an elevated prolactin on 2 occasions. It is a stress hormone. So basically, if a woman's running around and a bit stressed before she has the blood test done, it can be slightly elevated. So hence we do 2 to see that they're elevated on both occasions. Raised prolactin, once again, that interferes with the hypothalamus, and therefore it interferes with the FSH and the LH secretion, and therefore it can stop a woman from ovulating and they have irregular periods. They may have other symptoms such as galactorrhea or breast discomfort or visual field abnormalities. Basically, we order an MRI of the pituitary gland to look for prolactinoma. And most of us are comfortable looking after micro prolactinomas, so it's 10 millimeters or less, and we treat them with cabergoline, which rapidly brings down the prolactin and can restore them to ovulating on their own. We would tend to refer off to a neurosurgeon if they are large, or if they do actually have things like visual field abnormalities and defects. So thyroid disorders, we use a thyroid stimulating hormone to screen for these. So basically thyroid disorders includes hypoactive and hyperactive. So hypothyroidism and hyperthyroidism. Hypothyroidism is by far the most common that we see. And that most of us are actually, as fertility specialists, we're actually comfortable to manage hypothyroidism with thyroxine replacement. But if it was hyperthyroidism, I would refer them to an endocrinologist for treatment and ongoing care. So polycystic ovary syndrome, this is by far the most common cause of anovulation. So this is what we see in the clinic the most. A simple way of deciding whether someone's got polycystic ovary syndrome or not is they need to have 2 out of the 3 of oligoamenorrhea, so irregular periods, usually a prolonged cycle with only a few periods a year, clinical hirsutism and or biochemical signs of raised androgens. And the ultrasound criteria for polycystic ovaries is greater than 25 antral follicles per ovary. So basically the group that we often see for fertility are the ones having irregular periods and their ultrasound shows more than 25 follicles per ovary. And they, by definition, have polycystic ovary syndrome. We do need to make sure that we're on the lookout, that we're not missing something. It's like if the androgens are raised, we need to exclude Cushing's, congenital adrenal hyperplasia and other causes of anovulation. So to diagnose polycystic ovary syndrome, we do need to be a little bit wary to make sure we're not missing something a bit more serious. So investigations for polycystic ovary syndrome. Basically, polycystic ovary syndrome is related to insulin and insulin resistance. So we should screen all women with a fasting glucose and a fasting insulin. And in a woman who is overweight or obese with polycystic ovary syndrome, I would tend to do a glucose tolerance test, as they often have diabetes or pre-diabetes. And I would usually get them to have insulin levels done at the same time during the oral glucose tolerance test, and also test fasting lipids, because a lot of these women have got raised cholesterol, etc. as well, that should be looked at. If the androgens are raised, then we need to exclude congenital adrenal hyperplasia, Cushing's and androgen-producing tumours. We also need to pay attention to the endometrial thickness on scan, particularly if they have irregular spaced out periods, because women with polycystic ovary syndrome and anovulation, even at as young as 30 to 35, can have endometrial hyperplasia because they've had unopposed estrogens for so long. So the treatment is basically ovulation induction. There's a few different ways to do this. weight loss alone of 5% body weight can be enough for the woman to start ovulating on her own. We can also just use metformin. That works by increasing insulin sensitivity, thereby reducing insulin levels. It does seem to be something to polycystic ovary syndrome is complicated, but it does seem to be related to insulin and high insulin levels having a local effect on the ovaries to prevent ovulation. We also use our two most common drugs that we use for ovulation induction are letrozole and clomiphene, and they work by being an anti-estrogen and making the pituitary gland think that the estrogen is really low, and therefore the pituitary gland puts out more FSH in order to achieve ovulation. So then, therefore, that will cause follicles to grow up. We can also do ovulation induction with FSH directly with the injections if women don't respond to the oral medications. We do monitor our ovulation induction women because, especially with PCOS and lots of egg follicles, it can often be more than one egg follicle that's growing up. And so we monitor for two reasons. We monitor with ultrasound and blood tests, one, to see that they're actually responding, and two, if they are responding, how many egg follicles are growing up. Because obviously if there's 3 or more, then we cancel the cycle because the risk is too great having multiple births. Ovarian drilling, which is what's shown is here, is a nifty operation which we don't tend to do very much anymore because we don't do so many now that IVF pregnancy rates are so good. We used to laparoscope just about every fertility patient looking for endometriosis and blocked fallopian tubes, etc. And it's a relatively easy thing to do at the time of laparoscopy, and it's quite a neat operation where you actually just drill holes about 8 per ovary using electrocautery, and about 60 to 80% of women who've had that done will actually ovulate on their own and not need any further intervention. Some women who've got polycystic ovary syndrome and ovulation will end up having IVF if there's no success with the ovulation induction or if there's a concurrent male factor. So if there's something wrong with the semen analysis as well, well, then the couple might end up having IVF. That's just a pretty picture to break things up to show ovulation induction with the fimbrial end of the tube picking up the egg. So now to the other side of the equation, which is the sperm. So semen analysis is what we need to do, but...
Sorry, Jodie, just quickly, before you go on there, we just had a question in the chat about the ovarian drilling.
Yes.
How does that work?
So it probably works because it's reducing the amount of estrogen that the ovaries are producing. So women with polycystic ovary syndrome usually have sort of medium, their estrogen levels don't ever really go low because there's so many egg follicles producing estrogen. So it's believed that it causes a drop in estrogen and androgens, which then releases the pituitary gland to start putting out FSH.
Okay, thank you.
So with male factor disorder, when we get a semen analysis that's abnormal, it's important to take a thorough history from the male about previous surgery or trauma to the testicles, congenital issues such as undescended testes, whether they've had infections in the past such as mumps or STDs, obviously other illnesses such as cancer and chemotherapy. And we need to talk to them about smoking, drinking and drugs, particularly steroids. There's actually a lot of men who go to the gym who use steroids, which actually has a significantly bad effect on the semen. Basically, semen analysis, we usually do 2, particularly if the first one is abnormal, and they need to be done about 2 months apart because it takes about 2 months to produce a sperm. So if the male was unwell or something causing the first semen analysis to be abnormal, we need to repeat another one about 8 weeks later. So the new World Health organisation has strict criteria for percentage of normal shapes. So they're now a lot fussier about what they call normal. And a normal semen analysis is greater than 15 million per mil, greater than 32% progressive motility, and greater than 3% normal morphology, which is actually quite low, because that means that there can be 96% abnormal shapes, and that's still a normal semen analysis. Basically, the old criteria was 15% normal morphology, and anything less than 15%, it was noticed that there was a reduced fertilisation using just routine insemination with IVF. When we look at a male semen analysis that is technically normal, but they've only got 4% normal shapes, that's actually on the 5th centile of, basically they've developed these percentages in the normal ranges by looking at fertile men and their semen analyses. And 4% normal shapes is actually on the 5th centile. So it's actually quite low. So there may be a fertilisation issue at this level, which we then see when we do IVF. But the good news is that by performing sperm microinjection, so that's ICSI, I'm aware I've got lots of shorthands in my slides, but that's intracytoplasmic sperm injection or sperm microinjection, that can restore the fertilisation rates by doing IVF with these low semen morphologies. So investigations of an abnormal semen analysis. So if one semen analysis is abnormal, then it should be repeated 6 to 8 weeks later. As mentioned before, we need to take a thorough medical history, including medications and recreational drugs, a history of previous surgery and trauma. And we also need to examine the male testicles for the volume, make sure they don't have any tumours, and see if we can feel the vas deferens or not. If the semen analysis is abnormal, we need to aim to correct lifestyle factors like cigarettes, alcohol, and particularly raised body mass index. So a man who is obese can have an abnormal semen analysis, and that can actually be related to the fact that the testicle is supposed to be 2 degrees colder than the rest of the body. And in men that are obese, the testicles are subject to more heat, just from an anatomical perspective, and therefore they can end up with an abnormal semen analysis because of that. So investigations...
Jodie, is there a particular lab you send the semen to?
Yes, we do. We send it to SE Pathology.
And is there a time frame it has to be delivered, or...?
Yeah, within an hour. So the tricky SE Pathology is good because we trust their results, but it can be a bit, there's not many, so it has to be taken to one of the main laboratories. So it's got to go into the laboratory at the one behind the old Royal Adelaide Hospital, or Flinders Medical Centre, or Lowell McEwen Hospital. They're the 3 main places. There also are country places will accept semen samples, and it usually has to be taken there within about an hour of production at home.
Right, okay.
So basically, investigations of moderate and severe semen defects, including azoospermia, where there's no sperm at all. Basically, we do similar hormones to the hormones we check with females. So we check FSH, LH, testosterone, prolactin, and thyroid stimulating hormone. If we've got a reduced semen count and reduced FSH and LH, that sounds like there's something going on in the pituitary gland. So that would then warrant an MRI to look for a pituitary adenoma. We also get an ultrasound of the testes done looking for tumours, because there's actually an association between a poor semen analysis and an early testicular tumour. So all of us have picked up a few early testicular tumours on the basis of a reduced semen count. The ultrasounds these days can also tell us whether the vas deferens is present or not. We should be doing chromosomal karyotyping on men with moderate and severe semen defects. We should offer the Y deletion test, which is unfortunately not covered by Medicare. and it costs about $200. But it's important to know, not only to search for a reason, but because the male will pass this on directly to any male children he has, and also there might be family members who need to be tested as well. Cystic fibrosis mutations should be tested for when a man has absent vas deferens. There's a relationship between having absent vas deferens and carrying the cystic fibrosis mutation. So that's something that should be done if a man has either unilateral or bilateral absent vas deferens. Treatment options. So basically, if a male has hypogonadotrophic hypogonadism, which means that his hypothalamus and pituitary gland aren't working, therefore his testicles aren't working, the treatment, strictly speaking, would be FSH, but we actually usually give it as HCG, human chorionic gonadotrophin, because the half-life is a lot longer and it does the same thing. It can take quite a while to get the sperm count back up. It can take sort of 12 months or so to get the sperm count up to normal. So that's a long wait for people. So sometimes they will elect to be on the treatment, but they, depending on the female age, etc., they may look at IVF whilst they're waiting to get their semen up as high as possible. It may not ever return to normal. With mild sperm defects, such as reduced motility and a slight reduction in count, we might do intrauterine insemination. Severe sperm defects basically need IVF with sperm microinjection. Testicular failure is a situation where we don't have any sperm in the ejaculate, but it's not because the vas deferens is missing or obstructed. Basically, we need to do a testicular sperm aspiration to see if we can get sperm from these men. And then if we can, it would be IVF with sperm microinjection as a treatment option. If we can't get any sperm from a testicular biopsy, then unfortunately the only thing for the couple to consider is whether they would look at donor sperm. With obstructive azoospermia, such as a vasectomy that hasn't been reversed or an unsuccessful reversal, or an absent vas deferens, we do a PISA-TESA, which is a percutaneous epididymal sperm aspiration, or TESA is a testicular sperm aspiration. I do have a picture of this on the next slide. No, on the next slide after this one. So this is showing IUI. So basically, what's done here is that this woman is given FSH injections for about 7 to 10 days and tracked so that we can see when she's ready to ovulate. She's then given a trigger injection to get her to ovulate, and 36 hours later, they both come into the unit and the man gives the semen sample, which is washed, and that washed sperm, which usually contains the more motile or more morphologically normal sperm, is popped up into the uterus. So the way that this might work is by getting the timing exactly right and by getting a higher number of sperm up close to the fallopian tube, so doing 3/4 of the journey for the sperm. We need to have tested the woman to make sure that she's got patent fallopian tubes. And some groups, it's 15 to 30% chance of pregnancy over 3 cycles, which is not fantastic, but it's very dependent on patient selection. In men with low sperm morphology and couples with unexplained subfertility and endometriosis patients don't do that well with IUI. So it's only sort of a select population that it's really worth trying for. So this is the picture of the PISA-TESA. So this is a diagram showing that this is the epididymis, the storehouse for the sperm. So that's a PISA, percutaneous epididymal sperm aspiration. If the needle was going into the testicle to get sperm straight from the testicle, then it's called a TESA, testicular sperm aspiration. So when we've got severe sperm defects, the way we get around that. I'm going to go through IVF in a little bit of detail too towards the end of this talk, but this basically shows intracytoplasmic sperm injection, where the scientist individually injects the sperm straight into the cytoplasm of the egg. And basically the result is that if we get, we normally will get fertilisation using this technique, and the pregnancy chance with one embryo transfer is 50%. So there's plenty of hope for couples where there's male factor infertility. So we've looked at the eggs and we've looked at the sperm. Now we have to look at whether there's a problem with them meeting up. So we're talking about the tubes, we're talking about the fallopian tubes and whether they are able to carry the sperm up to the egg and whether they're able to carry the egg down to the sperm. We do ask them questions about whether mid-cycle intercourse is occurring okay, because about 5% of unexplained infertility is due to sexual dysfunction. So we do need to ask them whether there's any problems with intercourse. After a while that a couple have been trying, it becomes quite clinical. They're just aiming for mid-cycle intercourse, and understandably some men find it extremely stressful to have to do this on demand at a certain time of the month, and so they can have erectile dysfunction, which can be amenable to treatment with Viagra, etc. But if there is sexual dysfunction, then artificial insemination can be a way around that, and that's one group of people that can do well with artificial insemination. So assessing for tubal damage. So basically, if there's no specific history of things that may have damaged the tubes, then the first port of call for checking for tubal patency is, it's called a hypothesis, and that's a hysterosalpingo contrast sonography, which is why we call it a hypothesis, because that's far too long to remember. Basically, it's a matter of the woman goes into the radiology department, the gynecologist or the radiologist does a speculum examination, threads a little tube up into the uterus, and basically fills up the uterus with saline, and then they use agitated saline or a special medium that can be seen on ultrasound, and they can watch whether the medium comes out through the tube, so they can check for tubal patency. They also, these are the same ultrasound places I was talking about before. They also do the hypothesis for us, and they will also do an endometriosis scan at the same time. Hypothesis itself is therapeutic as well as being diagnostic. So flushing the tubes out just with normal saline or with their Ecovist medium can actually improve the chance of conceiving afterwards, possibly because of flushing out of tubes. Sorry, I've gone one ahead. Possibly because of flushing out of the tubes. I don't know whether people have heard of Lipiodol and a Lipiodol flush, but there's an option to do that at the same time as doing the hypothesis. Lipiodol is actually made from poppy seed oil, and it has been researched and found that flushing out the tubes with Lipiodol increases the chance of pregnancy more than just the hypothesis on its own. And we're not completely sure why that is, whether it has an anti-inflammatory effect in the pelvis or what it actually does, or whether it does a better job of flushing the tubes out, but it certainly seems to increase the pregnancy rate, particularly in unexplained subfertility. We may wish to consider laparoscopy if there's been a history of tubal surgery or endometriosis or appendicitis or infections like chlamydia. We could then consider doing a laparoscopy because we may be able to give the couple a better chance of conceiving naturally if we treat adhesions, endometriosis and blocked fallopian tubes. Congenital abnormalities that may cause tubal blockage, or basically a unicornate uterus, for instance, only has one horn and one working fallopian tube. So that's another reason for getting a good baseline ultrasound, which is normally done as a 3D scan as well on that basal ultrasound that I was talking about. And that's the way we can find things like a unicornuate uterus. So that only has one working fallopian tube, which means that the woman only has every second month has a chance to conceive, because on the other month the ovary will be ovulating and there's no functional fallopian tube on that side. So endometriosis, 1 in 10 women in Australia have endometriosis. If we look at the subfertile population of women, it's probably more like 30%. This is quite severe endometriosis. This is the uterus here, the ovaries here. This is the rectum, and there should be a huge gap between the rectum and the uterus, and there isn't, because there's endometriosis attaching the bowel to the back of the uterus, and the ovaries are pulled in as well. So endometriosis can cause infertility by anatomical distortion, where the tubes are pulled away from the ovaries, or the tubes can be damaged or blocked as part of the severity of the endometriosis. On a more microscopic level, endometriosis is an inflammatory process with a lot of inflammatory cytokines and other chemicals around the place. And there is evidence that the presence of endometriosis causes oxidative damage to the eggs or the sperm. And so that is more on a local level, that the egg and sperm are being damaged by the endometriosis. Also, painful intercourse in women with severe endometriosis may be preventing pregnancy or mid-cycle intercourse. So basically, the management of endometriosis is, we can actually, if we've diagnosed endometriosis on ultrasound and the woman actually doesn't have many symptoms, we don't necessarily have to go to surgery. Basically, the IVF pregnancy rates are the same whether endometriosis is removed or not. So, sorry, I've done that again. So basically, a woman doesn't have to have surgery on her endometriosis before doing IVF. And in fact, we have to be careful, because removing endometriomas from ovaries can reduce ovarian reserve, and it can actually have quite a marked reduction in ovarian reserve, because when we strip out the capsule of the endometriosis cyst, we also strip out some of the normal ovarian tissue. And then in order to achieve hemostasis, we actually have to diathermy the base of the endometrioma, which means diatherming normal ovarian tissue as well. So basically, we do have to balance things up when we're talking about surgery. If a patient has symptoms or they're wishing to avoid IVF, then in those cases we would look at surgery. But if a patient is asymptomatic and and their primary desire is to conceive, then we may well just go straight on to IVF. So other causes of subfertility are unexplained, as mentioned previously. Failed fertilisation, what we find in particular in the unexplained category is we go through and do a cycle of IVF and we get failed fertilisation. So we do routine insemination where we put the egg and sperm together to do their own thing, and they don't fertilise. And what that shows us is that that's probably what's been happening out in the wild, in the wide world. They haven't actually, the sperm and egg haven't actually been able to fertilise each other. There's also implantation failure and recurrent miscarriage, which is another whole topic on its own in terms of causes of subfertility. So who needs referral? Basically, all couples who are concerned about fertility should be offered a consultation with a fertility specialist, should they like. But further investigation should be offered after 1 year of failing to conceive. We should be thinking about doing investigations earlier in women who are greater than 35 years of age, and in women who are presenting with signs of anovulation, such as really irregular periods, or if they've got a history of pelvic surgery, endometriosis, or there's a history of male factor issues. Also, a family history of early menopause. A woman who's got a family history of early menopause should have a fairly early assessment done of her ovarian reserve, maybe even like only after trying for 6 months or even less. So in terms of GP instigated investigations, So what you guys can consider doing, if you want to start the investigations for a couple who have subfertility, you can do baseline bloods day 3, 4, or 5 of a period, and that's follicle-stimulating hormone, luteinizing hormone, estrogen, anti-Müllerian hormone, thyroid-stimulating hormone, prolactin, and then androgens if indicated. It's also a good time to do the routine antenatal serology in terms of Hep B, C, and HIV, VDRL for syphilis, rubella and varicella to check that they're immune to those, and vitamin D level. If they have regular cycles, you could organise a luteal progesterone. And the other thing that can be organised if you feel comfortable doing it is to organise a baseline pelvic ultrasound at one of the places I was mentioning, and ask for ovarian volumes and antral follicle count and an endometriosis scan. The other really helpful thing is for them to have had a semen analysis done, because if they've had a semen analysis done before they come to see us, that gives us a lot of information, a huge amount of information, rather than a couple coming without a semen. Because if we've got a semen analysis that's normal, then we're going to start looking more into tubal patency testing and things like that. If we have a semen analysis that is abnormal, then we're going to start investigating the male. But understandably, not everyone feels comfortable ordering a semen analysis, but if we don't have a semen, we don't have much information to give the patients at the first visit, and it tends to be that we just have to send them off for a semen analysis before we can tell them much else. So I was just going to talk briefly about IVF. I'm running a bit behind time, but I'll do this quickly. So basically, IVF at a glance. An antagonist cycle is the most frequently used cycle in South Australia. It involves about 2 weeks or 12 days of injections, and the cycle starts with a period. During the first week of stimulation, we are stimulating the woman's ovaries to grow up multiple follicles with follicle-stimulating hormone. During the second week, we introduce a gonadotrophin-releasing hormone antagonist, and that is to prevent the LH surge from happening. So we don't want the woman to ovulate her eggs before we have a chance to collect the eggs. So that's the reason for that. We use transvaginal scans to look at the follicles growing up. So these follicles are growing up, this one isn't. We use a trigger injection when the follicles are up to size, and we collect the eggs 36 hours after the trigger injection is given. This is a diagram showing our oocyte retrieval egg pickup. So basically we use a transvaginal scan with a needle guide, and we suck the fluid out from the follicle, and about 80% of the time the egg comes with it. We then hand the egg straight over to the scientist that's in theatre with us for them to count and look at and put the eggs in culture media and look after the eggs in a 37-degree temperature humicrib. What happens in the lab? This is with routine insemination. Basically, the egg and sperm are put together in close proximity and sort of forced together, forced to interact, so that hoping to achieve fertilisation that way. The next day, the scientists can tell us how many of the eggs are fertilised. And then for the first 3 days, the embryos just divide. Each cell divides once per day. So on day 1, we have a 2-cell embryo. Day 2, we have a 4-cell embryo. Day 3, we have an 8-cell embryo. And by day 5, we have what's called a blastocyst, which is a ball of cells with fluid in the middle and an inner cell mass. The inner cell mass becomes the baby, making part of the embryo, and the outer layer of cells becomes the placenta. IVF is a numbers game, so we get a drop-off all along the way. We don't get 100% fertilisation. So say we start with 10 eggs. This is all very average data. Every couple's different as to what happens to them. But on average, if we start with 10 eggs, we might get 7 fertilised. And of those 7, we might get 3 that get through to blastocyst stage. The other way of inseminating is with VIC, which we've gone through. So basically they use a very fine glass. I don't know whether you can actually see, but there's actually a sperm in there right there. It's a very fine glass pipette that they basically inject the egg with a single sperm. These pictures are of a fertilised egg, a 4-cell embryo, an 8-cell embryo on day 3, and that's a picture of a blastocyst, which is a lovely ball of cells with fluid in the middle, and this tighter ball of cells here is the inner cell mass that becomes the baby. This shows a hatching blastocyst where it's hatching out of the zona pellucida. It's getting ready to implant, so that's sort of on day 6 when the embryo should be back in the uterus. And this just shows an embryo transfer process, which is a little bit like the IUI, where we thread the catheter. The woman is awake for this. We use a speculum, we thread the catheter up inside the uterus, and we deposit the embryo with a little bit of culture media in the mid to upper part of the uterus. So what's been exciting, I don't know how many people know or understand what's happened, but we've partnered with Genea. So we're now Genea Fertility SA. And the big win for this is that we've got access to their technology now, and we've got, our whole lab has been decked out with these new U-Butte incubators, which allow us to culture the embryo undisturbed for 5 days. Basically, it allows, the normal way of doing things is with sequential culture media, where the media has to be changed on day 3. So there's a different culture media for the embryos up to day 3, and then it changes the culture media on day 3. So that means manipulating the embryos and moving them from one culture media to another. With these new Jerry incubators, it allows continuous culture media through to day 5. And this means the embryos are cultured without being removed from the optimal environment. It also allows for time-lapse photography. And in the not too distant future, we're hoping our patients will have access to real-time photos of their embryos. Studies done at Genea have found improved pregnancy rates and live birth rates with the Jerry incubators compared to sequential media in standard incubators. And so we're quite excited by this. I mean, anecdotally, I can already say that I've had some people who were having difficulty getting good blastocysts previously, and we've just done their cycles using the new Jerry incubators, and we're getting better blastocysts. So that's really quite exciting. And the goal of treatment is a single healthy baby born at term. And I'm sorry I've gone over a little bit, but that's me done.
No, Jodie, that was excellent. That was exactly what we're after tonight. Again, that was sort of fertility 101 for the majority of GPs probably sitting in the group today. There was one question along the way that talked about, you talked about using the HCG injections. I think for
male.
Yes. Is there a chance that can cause polycythemia? Do you know?
I don't know. I don't know why it would. Was there any?
No, it was just someone was curious that they thought maybe it caused that as a side effect, but you know, I didn't know how common it was.
Yeah, no, I don't think so. I can't see why, because we're just replacing something that they don't have much of. So
all right.
I might have to go and Google that one now.
No, that's all right. So, guys, if anyone has any other questions, just unmute yourself and you can ask Jodie a question while we've got her, and then we'll wrap it up in 5 minutes or so. So, if there's any questions, just unmute and ask, or chuck it in the chat. Otherwise, I thought the presentation was brilliant. It was. I learned a lot.
I had to talk fast. Sorry, I had a few too many slides, I think.
There's one question there about what are the chances for women over the age of 40 falling pregnant?
With IVF?
Yeah, with IVF.
So basically 40 to 42. So there's still a chance. So our 40 to 42-year-old age group, we are getting a pregnancy rate of about 35%, I think, in 40 to 42. But then there's a high miscarriage rate, unfortunately, of nearly 50%. After age 42, it starts getting really tough. So 43, 44, it's a much lower pregnancy rate. And once we start getting to 45, it's really low, like just a few percent, and over 45, so 46 and over, it's basically zero chance. So things really drop off in that early 40s to mid 40s.
We're not getting many questions in the chat. We're just getting a lot of, that was a great talk. That was very comprehensive. Thanks so much. So with referrals for IVF treatment then, if we've got patients that are 46, should we be referring them to you guys? Or is there a limit to an age, what you'd see, or?
I mean, we'd always see somebody for counselling, but we are not doing IVF we have decided as a group that after the age of 45, so 46 onwards, the chance is futile. So the risks are outweighing the benefits.
Yeah.
So we're not routinely offering IVF to anyone 46 and above. Obviously, sometimes somebody really wants to try, especially if they haven't been trying for long or whatever, or other circumstances. And we'll have a chat as a group of doctors and make a decision about whether we might just offer them one cycle to see where they get. But the tricky thing is that we can often create embryos, but they're just all chromosomally abnormal or not competent. So it can be quite confusing to a couple if they are actually able to produce embryos. It's very difficult for them to understand why they're not getting pregnant.
Yeah.
But we have recently decided on an age cutoff, but as mentioned, we do discuss, do have case studies that we discuss amongst ourselves as a group of doctors to work out whether it's reasonable or not to do a cycle. So we wouldn't say no to a referral, so because we can then counsel the patient, but we would love it if it was mentioned that it was not a good chance before, so that we're not the ones giving them the nasty surprise.
Yeah, and the other question is the miscarriage rate independent of the egg quality?
Egg quality, so is the miscarriage rate independent of egg quality? Well, I guess if you're talking about chromosomes, as egg quality is whether the egg is got normal chromosomes or not. Well, the main cause of miscarriage is abnormal chromosomes. So then in that respect, egg quality that's related to chromosomal abnormalities will increase the miscarriage rate.
Yeah, okay.
We also, I guess we can also, it can also still be a miscarriage of a chromosomally normal pregnancy, but if the egg quality hasn't been perfect in terms of mitochondria and energy production, then I guess there's a possibility that there's a miscarriage of a chromosomally normal embryo that is still age-related.
Yeah. And are they doing some studies in omega-3 and miscarriages in South Australia now? Is that happening?
A lot of women are on fish oil already. That's one of the things that they take. I don't know of any particular study going on.
And what about if older couples use egg donation, does the chances improve?
Absolutely. So basically, it's not a problem with the uterus; it's a problem with the eggs.
Yeah.
So if we and we offer known donor, but also we have donor eggs from the US. So people can buy eggs from the US and they are sent over to us here. And our pregnancy rate with the frozen eggs from the US, they buy 6, it costs a fortune. They buy 6 eggs for about $15,000, but we've had a pregnancy rate of about 70% using donor eggs from the US. Yeah. So age-related infertility for the female is related to the eggs, not to the uterus.
Okay. And this, you might not know the answer, but is it possible to access superannuation for IVF?
Yeah, it is. So people are getting access to their super on compassionate grounds, but I know they're having to go through seeing a psychiatrist, but there's actually a website or something called Access My Compassion. There's something that they're finding on the web anyway. And they actually need a psychiatrist to say that they are distressed and distressed about their infertility or subfertility, and they can actually access their super for treatment.
Okay, excellent. And actually, no, one of the doctors told me the omega-3 replacement is about preventing premature labour for pregnant women. That's what.
Oh, premature labour. Okay.
Yeah, my fault. All right, thanks so much, Jodie. That was a brilliant presentation. I think everyone thoroughly enjoyed it. We really enjoyed having you here tonight, and I really appreciate your time.
No problems. Thanks for having me.
That's okay. So we're going to call the meeting to a close, and I'll log off. So thanks so much, guys. See you next time. Thanks so much, Jodie. Enjoy
No
the
problems.
rest of the weekend.
Thank you.